Welcome everyone to the Canadian Nurses Association's webinar series, Progress and Practice. This webinar is supporting nurses to choose wisely, how to reduce overused and unnecessary treatments and interventions in critical care. This session is being recorded for nurses who are unable to participate today. Next slide, please. My name is Aidan Hamza, and I'm the Acting Program Lead for Policy and Government Relations at the Canadian Nurses Association, and I will be presenting this webinar. At the end of this presentation, we will answer your questions, which you can type into the Q&A box that you see to the right of the slide. We'll address as many questions as time allows. The certificate of participation will be emailed to you along with a link to the recording of this webinar. And now a little bit about our presenters, Kathy Baumeister and Matthew Wenger. Kathy Baumeister has been a registered nurse for 40 years and is the past president of the Canadian Association of Critical Care Nurses. Kathy is the chair of the Choosing Wisely Canada Nursing Group Committee, comprised of registered nurses all across Canada. Kathy has been a critical care nurse for the last 20 years and continues to advocate on behalf of nurses, patients, and their families who find themselves in the critical care unit. Matthew Wenger found his passion when he started nursing at the adult MS ICU at the Royal Alexandra Hospital in Edmonton in 2011. His commitment to professional development is evident in his most recent involvement with the National Nursing Working Group that has developed the Choosing Wisely Canada Critical Care Nursing List. He lives in Calgary, Alberta, and works at the Foothills Medical Center in adult critical care, and is completing a Master's of Nursing with an adult acute care nurse practitioner focus. And now we're to you, Kathy and Matt.
Thank you, Aidan, for the introduction. And I would like to thank the Canadian Nurses Association for giving us this opportunity to share with you our recommendations in the Choosing Wisely Canada campaign for critical care nurses, their patients, and their families. It is especially important that this webinar is occurring during the Canadian Intensive Care Week. This week is an opportunity to reflect on our practice, promote the work we do, promote our workplace, and acknowledge our co-workers and celebrate the intensive care team. During our presentation, we will be covering a brief description of the Choosing Wisely Canada campaign, how critical care nurses were involved, and how the list was developed. Matt will be presenting the 5 recommendations with examples of why, when, and how you can integrate statements into your practice. He will share with you how to access the list and an update of the implementation plan. Next slide. Thank you. The Canadian Association of Critical Care Nurses is an organization that promotes and supports critical care nurses in Canada. We have 15 chapters across Canada with our national office located just outside of London, Ontario. We have just over 300 members. Our mandate is to provide educational opportunities and ongoing support to critical care nurses across Canada, including the military and international members. When we first ventured into this collaboration with CNA, Carrie Schuhander stated the importance of belonging to our associations. Quote, as a member of the CCN, you have the opportunity to participate in research that influences the future and the role of nursing, unquote. This statement describes why it's so imperative that we as nurses need to be active in our provincial or specialty organizations, including working with our national representatives within the Canadian Nurses Association. These organizations can only speak for us if we share our voice. Now, later, we need to continue to recognize the vital role nursing plays. I'm proud of the work that the committee and CNA have accomplished, and I am privileged to be able to present the work of the committee to you today. Our vision statement, the state of the art of nursing, combining compassion, technology, and evidence-based practice when patients and families need us most, transects nicely with the Choosing Wisely Canada campaign. Next slide, please. I'm sure many of you joining the presentation today are well aware of what critical care is. The next few slides contain information taken from the document produced by the Canadian Institute for Health Information entitled Care in the Canadian ICUs, which was published in 2016. Next slide. The Choosing Wisely Canada campaign includes the stakeholders, the physician, the registered nurse, the patient, and their families. It is important to know who the critical care patient is. Typically, our patients have an unplanned admission to the critical care unit in response to a sudden change in patient condition, either in their home environment or in a hospital setting. Once they've arrived in the ICU, patients are typically sedated and then intubated. They're unable to advocate for themselves, and their families are under an incredible amount of fear and stress. Next slide. Our patients have typically undergone any number of invasive procedures, which include urgent intubations and line insertions, and within any given 24-hour period, the critically ill patient may be transferred to radiology for interventions or diagnostics, and may or may not require urgent or emergent procedures and surgeries. They may also require one or more of the following interventions, including aortic balloon pumps, renal replacement therapy, or intermittent hemodialysis, ICP monitoring, lumbar drain monitoring, or ECMO. And these are just a few of the interventions that we provide. Next slide. It's a very simple fact that the critically ill patient is one of the most vulnerable and complex patients within the healthcare system. If a patient survives this hospital admission, their life is often changed. The fact that we perform these invasive but life-sustaining procedures can lead to an increased risk of complications, including but not limited to hospital-acquired pneumonia, hospital-acquired infections, and sepsis, which can contribute to death. The Choosing Wisely campaign is aimed at reducing treatments and procedures that cause harm and that are overused or could be considered unnecessary. The campaign's goal is not to minimize or restrict care, but to enhance our practice. One could argue that it could be the future of care revisiting the past. In nursing, the care we provide could be considered anecdotal at times. However, to advance our practice, we strive to combine the art and the science of nursing using evidence-based practices. These recommendations are a tool to support the care we provide. We know what we do works, and we have the evidence. Next slide, please. Canadian Nurses Association and members from their specialty organizations were invited by Choosing Wisely Canada to develop a general nursing list. Next slide. Currently, the CAA and the CWC have 3 lists, with the critical care list being the 4th that has been developed. As you read through the lists, you will find that many statements overlap. However, as we work through our critical care list, you will find that the statements, the evidence, and the research are based on critical care practice. Next slide, please. Next slide, please. CNA has had a partnership with Choosing Wisely Canada since 2015 and developed the first non-medical Canadian nursing list of recommendations titled 9 Things Nurses and Patients Should Question. Following the release of the first list, CNA received positive feedback from their members and an increased interest, particularly with nursing specialties. CNA recognized that there could be an opportunity to further support nurses through the CWC list. Recognizing the expertise and interest that exists within these specialty groups, CNA initiated a call of interest to the network to see if there was a continued interest in the development of the specialty-specific recommendations. Next list. Next slide, please. CNA responded to the call. An email was sent to all members of the CACCN asking for volunteers to sit on the committee to develop a Choosing Wisely critical care nursing list. This call for members was made in late 2016. Members of this committee also had to be members of the Canadian Nurses Association. In May of 2017, we had our first teleconference meeting. Thereafter, we had meetings every 6 to 8 weeks to review, research, and refine the recommendations. As with the previous list, the Delphi process was utilized to test the statement's validity and finalize 20 items. We also met with CWC representatives to ensure that the recommendations met their guidelines. This reduced the list from 20 items to the 5 statements we will be sharing with you today. Specifically, the recommendations could not be a do disguised as a don't, and must be an intervention that was overused, could cause harm, or was unnecessary. In January of 2020, the completed list was reviewed by CWC and their stakeholders, and then forwarded to both the CNA and the CACCN board for their endorsements. In July of 2020, in a combined social media blitz between CWC, CNA, and CACCN, we released 5 things critical care nurses and patients should question. Next slide, please. Our working group was made up of critical care nurses from across Canada. We had representation from all aspects of nursing, including academic, research, clinical nurse specialists, managers, and critical care nurses working at the bedside. I would like to mention that this list would not have been developed if not for the ongoing support from the Canadian Nurses Association, and specifically Aidan and Carrie. Their work was invaluable in the completion of this list. Next slide. I mentioned previously that the recommendations could not be a do disguised as a don't statement. As we developed the list, we knew that there were several practices that we wanted to address, but it didn't meet the mandate of the Choosing Wisely campaign. For example, I think one thing we can all agree upon is the importance of sleep hygiene for patients in the critical care setting. As you know, the lack of good sleep can increase the incidence of delirium. A second example is the importance of family presence in the recovery of a critically ill patient, really in all aspects of nursing. Next slide. To ensure the validity of the statements, a consultation process was mandatory. The consultants included nursing experts in patient safety, patient and family advocates, CWC internal reviewers, as well as CNA's own Canadian network of nursing specialties. Each group was invited to review the ingoing proposals. As a result of this consultation, we can share with you today nursing critical care, 5 things nurses and patients should question. Next slide. This is a visualization of the process for the development of the nursing list. Although the slide is linear, a number of the processes were being completed or occurring simultaneously with each statement. The original list of 166 items that was provided to us was divided into medical specialties. From that list, we were able to pull out 20 statements that were nurse-driven or practices that we had influence over as critical care nurses. The working group was also invited to provide independent statements. Each member of the committee took the list of statements and completed the Delphi survey. Once this was completed, each member took a statement and was responsible for reviewing the evidence. Next slide. So now I would like to pass on the remainder of the presentation to Matt. Thank you.
Thank you, Kathy, for the detailed explanation of how critical care nursing list came together over the last number of years. These 5 items are not exhaustive, and some of you may have thought about them already in your daily practice. I would like to take the opportunity to highlight each in the coming slides and how they apply to our critical care nursing practice. Next slide. So don't insert or leave in place a urinary catheter without an acceptable indication. So as we know, indwelling urinary catheters are invasive devices that require daily assessment and should be removed early to reduce the possibility of a healthcare associated infection. I recently heard a talk on continence management from Dr. Weg from the University of Calgary. Dr. Weg stated, Foley catheters can have a bacterial colonization rate of approximately 5% per day, with 100% colonization by day 7 to 10. Dr. Weg noted Foley catheters should only be used in the following situations: when patients with voiding difficulties, as a result of neurological disorders that cause paralysis or a loss of sensation affecting urination, for the avoidance of contamination or to promote healing of severe pressure wounds, for inoperable urethral obstruction that prevents bladder emptying, and for the improved comfort for end-of-life or palliative care. After listening to this talk, I realized how important our first item on urinary catheters was on this critical care nursing list. Patient examples that may be important to assess daily in critical care are those who are anuric on CRRT or are intermittent hemodialysis, or those with delirium, as catheters can be a source of agitation. And for those who are morbidly obese or have wounds, and for those who need mobility strategies versus containment and clean strategies. As bedside providers, we need to be mindful of all of these factors and ensure we can advocate for optimal patient care to reduce the incidence of catheter-associated urinary tract infections and the duration of the catheter indwell time. Next slide. So don't administer benzodiazepines to treat symptoms of delirium. So in the intensive care unit, delirium prevention, diagnosis, treatment can be quite complex. So when looking after a person with delirium, we must always think about 8 key delirium domains, and they include an initial check for acute and life-threatening causes, the identification and treatment of causes to optimize conditions for brain recovery, to detect and treat distress and agitation, to prevent complications associated with delirium, to communicate the care plan with the patients and their caregivers. We want to monitor for delirium recovery, and we want to promote rehabilitation even while the patient is in a state of delirium. And we want to also consider dementia and follow up for those who are typically in their sundowning phase. And sometimes this happens outside of the ICU. Other strategies to mitigate delirium include frequent reorientation and socialization activities, promotion of sleep hygiene, and minimization of sleep deprivation. We want to increase their arousal state. We want to provide mobility and the use of visual and auditory aids and early mechanical ventilator liberation. Delirium has been a challenging consequence of COVID precautions, as some hospitals across this country had to cease patient and visitor contact during the lockdown measures. As bedside practitioners, our role in recognizing delirium has never been more important during these times. Remember, there have been no medications, including antipsychotics and benzodiazepines, which have been consistently shown to prevent delirium or improve outcomes, such as length of stay or mortality. Next slide. So number 3 on our list, don't use physical restraints with critically ill patients as the first line choice to prevent self-extubation or removal of lines or tubes. So as we know, restraints can come in 4 primary forms: physical, mechanical, pharmacological, and environmental. In the intensive care unit, all 4 types can pose significant harm to our patients, such as increased agitation or delirium, the risk for injury, and functional and cognitive decline in some patient populations. The use of physical restraints can be minimized by maintaining direct visual observation of patients, permitting the presence of family members to participate in care, initiation of spontaneous awakening, so reducing that sedation, and initiation of spontaneous breathing trials, and assessment of delirium and the continued need for mobilization with the goal of greater than 2 mobilization points per day. Restraint use should always be a means of last resort, and it is important to be consistent with daily assessment and institutional policies that include information on restraints as a last resort. If a restraint is needed, ensure the least restrictive is utilized first. There is a shared decision-making process among the patient, family, and the bedside staff, provided a supportive balance between the patient and others' safety and minimize restrictions on patient liberty. So ask yourself, does my patient need physical restraints today? Could they tolerate a restraint holiday? Next slide. So don't repeatedly attempt intravenous access during a life-threatening event when intraosseous access is available. The intraosseous or IO route is preferred in emergent situations when intravenous therapy and medication administration via a peripheral or central venous access cannot be obtained. IO access can significantly benefit the patient's morbidity and mortality. Remember that an IO is a bridging device until a suitable peripheral or central venous access can be obtained. IO lines should be removed as soon as possible once other venous access is obtained or within a 24-hour period of insertion. 6 sites can be used for IO insertion. We have the right and left proximal humerus, the right and left proximal tibia, and the right and left distal tibia. The preferred location is the proximal humerus. This site has demonstrated superior flow rates, reduced time for fluids and medications to enter central circulation, and has less discomfort than a tibial site for a conscious patient. We also have to remember that IOs are not used for laboratory studies, infusion of TPN or chemotherapy, and medications with a high extravasation risk, and they should be used cautiously, such as hypertonic saline, for example. Also, IOs are not MRI compatible. IO insertion, management, and care is considered in some institutions as a specialized clinical competency. So even if you are not certified in IOs, it is important to assess if IO access is available for use and advocate for them where venous access is paramount. Next slide. Number 5, last on the list, but not least, don't prolong the use of central venous or peripherally inserted central catheters without daily reassessment. So minimizing parenteral access while in the intensive care unit can be a daunting task. However, central line associated bloodstream infections have significant patient morbidity, they extend the length of stay, and they increase healthcare costs and even can be associated with mortality. This hospital-acquired infection is entirely preventable. Appropriate management strategies that mitigate central line associated bloodstream infections include daily assessment of the venous access device, removal of the venous access if they are not part of the continued plan of care, or if the lumen remains dormant for greater than 24 hours. We must ensure that all ports are accessed with an aseptic technique. We must maintain a closed system as much as possible. We want to adhere to proper infusion tubing policies, and we want to ensure and maintain appropriate catheter dressings. Remember to advocate for the least invasive device for the intended and planned therapy with the lowest replacement or complication rate. Next slide. So with our practice recommendations that we've gone through on the list, we've created CNA poll question here. And the first one will be, will these critical care nursing recommendations influence your practice? And if you are online currently, you can answer that question. And then the second question, if you can access your Zoom browser, we're inviting you to type into the chat box on the Zoom browser. And so the second question is, what are some ways you can share this critical care nursing list with your colleagues? Yeah, so if we can get the poll answers up here, if possible. So yeah, it's loud and clear that these critical care nursing recommendations will influence your practice. So that's fantastic. And then in our chat window, if I can read it through. So what are some ways you can share this critical care nursing list with your colleagues? And some of you have already chimed in with some brainstorming. So at nursing huddles, fantastic. Print a copy within discussions, yeah. Huddles and quality councils, perfect. Yeah, even back on your social media, so Facebook groups, your WhatsApp group, during rounds, yeah. Yeah, bringing up the use of restraints within your practice. Yeah, laminate and put on your educational board, perfect. And then through daily rounds is a common theme. Someone had mentioned, yeah, we have already implemented many of these in our ICU unit. That's great. Again, this list is a national list, and we're trying to capture and speak to critical care units across this whole country. So that's fantastic that you have implemented some of these already. Yeah, bathroom boards, perfect. Yeah, I think you've got it all there. Social media again, yeah, perfect, through emails. Perfect, thank you. That was great.
I would just like to mention too that this list is available through Choosing Wisely Canada. I think all you have to do is go onto their website and you can actually request a package from Choosing Wisely Canada, as well as I think these are all great recommendations. And I especially like the idea of the nursing huddles. So maybe once a month, focusing on one of these statements, say, how can we impact this youth? And I know for myself that when we first started working on the list, I recognized that I started using them right away. As soon as we would talk about a statement, I would start to question the use of particular practice. For example, catheters, you know, do we need this catheter in this patient? What would be the best thing? And I think it does change your practice for sure. So thank you for all of your comments. They've been great.
Someone asked, is this published? And it is. So it's on the, not published, but it is posted rather on the CNA website. And Kathy, I don't know if we are going to include it in our Journal for Critical Care Nursing in Canada.
So there are a number of articles that have gone into our sorry, I'm losing my thought process here. Our Journal of the Canadian Association of Critical Care Nurses. I believe that list will be published in September if it has not already been published. And there is an article regarding how the list was developed by Basil in the CNA, as well as there's an article in the CACCN journal regarding the list. Aidan, maybe you can elaborate on that a bit more?
Yeah, absolutely. So I was just going to say, I put in the links both in English and in French in the PDF links to the list, so you can access it in the chat. It will also be circulated. Everyone who attended today will get an email from CNA, a post-webinar email, which will have the links to the resources as well. And just to follow up with what Kathy and Matt had mentioned, there is an article in the Canadian Journal for Canadian Critical Care Nurses, written by one of our great members, Claire Fielding, who helped us develop this list. And she wrote a great op-ed in that journal, as well as the list is posted in there as well. I think that was in the August or September journal that was released. And I believe even if you are not a CACCN member, they've actually made the op-ed and the list public access. So you don't even have to have access to the journal to be able to access it. And that's on their site. And I think Matt also just presented or just posted the link for the Canadian Nurse article that was written by another one of our working group members. He wrote a great article for us for the Canadian Nurse. And as well in that you'll find links to both the PDF as well as some other key resources.
And Barbara Fagan mentioned that it has been published in the fall Canadian Journal of Critical Care Nurses, so that's fantastic. So we're already talking about this, so next slide, please. Yeah, so the access and dissemination piece. So as we've discussed through Choosing Wisely, through the CNA, through our Canadian Association of Critical Care Nurses, and then as we've already discussed, journal clubs, leadership, team meetings, social media. So that's all perfect. You've all hit it on the head there. Perfect. I want to thank everybody for that, for all of those comments. And we can move on to poll questions if there are any.
Perfect. Thank you, Kathy and Matt, for that really engaging and enlightening presentation. Before we move on to the Q&A period, we'd like to ask that participants answer a couple short survey questions about today's webinar. So you should see those questions show up on the slide now. We will now start the discussion portion of the webinar. So if you haven't already, please type your questions into the Q&A text box, which is there at the bottom. And I see we already have some questions there. And maybe I'll start with the most recent question. Has there been any considerations to look at, this is a great start to establishing guidance to support patient care in the ICU environment and appreciate the inherent challenges in gaining consensus. The question is around, has there been any consideration to look at fluid administration? We know from recent publications, there's an increasing body of literature focused on administering fluids only if the patient is determined to be fluid responsive through SV monitoring. Do you anticipate that these will be integrated to the list at some point? And I see, Kathy, you'd like to answer that question?
Sure, yes, I would. So actually, to be honest, this didn't actually even hit our radar when we were actually looking at the list initially. I think that this is actually a good thing to probably review in the future. The list is actually reviewed on a 12-month cycle. So next year at about June or July, we'll be looking at the recommendations, looking at anything else we can add. So I think this is something that we could certainly start to look at and put in for is the research. I hope that answered the question.
Perfect, thanks, Kathy. The next question speaks to the IOs. They'd like to elaborate a little bit on the use of IOs. The ACLS guidelines prefer IV access over IO. What is your recommendation for staff? Are there a certain number of attempts before going to IO?
Yeah, I guess I can speak to that. For our list for number 4 rather, so don't repeatedly attempt intravenous access during a life-threatening event. So that life-threatening event would be referencing, say, a code 66 or a rapid response team call or a code blue call, or maybe the situation presents itself in your own intensive care unit where you do not have appropriate peripheral and or central access to mitigate or help that patient through their process. So I apologize. Yeah. So across the country, we might have rapid response teams or medical emergency teams that respond to pre-code blue calls or pre-arrest states. So if you are in those situations or within a code blue situation, the IO access might be your best friend if there is not appropriate intravenous or central venous, peripheral or central venous access. I hope that has answered your question. It's more for the more life-threatening situations.
Perfect, thanks, Matt. And I'll also just add that these are also recommendations that sometimes may be appropriate, sometimes may not be appropriate, depending on the situation, but are more just reminders for that critical thinking piece to make sure we're looking at all the options available for our patients. And I did want to ask a question. I know, Kathy, you had alluded to earlier. Have you guys found that doing this process, has that impacted how you personally care for your patients?
Hi, yes. As I had stated earlier, when I started working on this list and things, I started and reading the research, I started to change my practice. I wouldn't say significantly, but started to question things on a daily basis regarding restraint. So I just noticed there was a comment about how do you actually change the culture about restraining patients. And I think it's one person at a time. I know that I'm often the first person to take a restraint off a patient, and I watch them, and we have, and then I think as a senior nurse in critical care, I think we can change practice by gentle persuasion versus forcing people to do something, because of course they have to feel comfortable in their practice. And I think it is a thing when you're comfortable in your practice and you know your patient, I think it's easier to do things like unrestraining patients and recognizing their behaviors. I know that with workloads and reduction of staff, it can be made it can be challenging because you're trying to do the very best you can and prevent any accidental removal of lines. But I think it is at the end helps with the delirium. So I go through this whole thing. If I'm at a code and we're having problems getting a line in, until recently, we were not certified as registered nurses to put the IOs in. Now we are, and that would be something that as a member of the code team, I would certainly probably, a minute, give everybody a minute to kind of get settled into their roles. And if we can't get access within a minute, I would say that we would need to have to go to IO. And if I'm working with a team who is not certified to put in IOs, like myself or another registered nurse, then I would certainly recommend it and use my voice to say, we need to get that IO into this patient now because we need to give the drugs. So that would be some of my, I wouldn't not necessarily use an IO in a code 66 or a MET team level call, but definitely for the code blues.
Perfect, thanks, Kathy. And we'll just go on to the next question from Erica. What supports are in place for nurses advocating for patients who are receiving care deemed futile or unnecessary treatments? And so maybe you can speak to some of the challenges and potential opportunities to gain support in your units.
I can certainly appreciate that question, but I don't think that the question is inside the scope of this presentation. And I think this is more of an ethics conversation. Yeah, I don't really have an answer for you, Erica, other than I think that this is something that we all face. I think if you were to go through the list and say, maybe utilize that for your practice, and off the top of my head, I'm not sure how you could. But yeah, I apologize. I think it's outside the scope of this presentation.
No, I agree, Kathy. And I think that hopefully these lists help, work as kind of evidence-informed recommendations that you can bring to those interprofessional conversations when as acting as patient advocates for your patients. But yeah, I agree. And I'm just looking at a lot of great comments and a lot of great questions from everyone. One of the questions comes from Maggie, who here in the chat box. Do these recommendations come with any recommendations for staffing ICU patients? And I know that that's likely a potential challenge, but wanted to bring that forward and pass it over to either Kathy or Matt.
Sorry, Aiden, what was the question?
No worries. It was talking about recommendations that if these recommendations come with any recommendations for staffing ICU patients. And from my understanding or knowledge with these lists, they currently don't. But I would say that maybe these could act as a way to show the level of care that can be provided when you do have appropriate staffing. But I didn't say that these recommendations link to any staffing ratios or anything like that. Would you agree, Kathy?
I would agree that, again, that's outside the scope of the staffing recommendations. I know that nurse-patient ratios are always are a topic of interest, and I know CACCN has often, we've done research, there's been research done on it, but nothing, there's no clear-cut answer what staffing nurse-patient ratio should be, whether you're in critical care, acute care, home care, or clearly long-term care. I think that, when we talk about last restraints, when you look at the information we read, nurse-patient ratios, for example, in Europe are typically on the continent are 1-to-1, or the say that I read. In other areas where I have met people who have worked in England and things where they use very little restraint, they are as well 1-to-1, but that ratio may change. I think it's worth a conversation with your team and with your unit council to say, these are the recommendations. How do we utilize these recommendations, knowing that restraints cause delirium and cause confusion and all of these other things. So I think it's worth using these lists for these types of conversations with nurse managers or your unit council.
Mm-hmm. Great, and we also have another question from Joanne, which talks about working with your colleagues. How would you recommend convincing nurses who use restraints frequently and may potentially over-sedate to use these recommendations?
I think I talked on that briefly. I think senior nurses utilizing this, it's probably more of a gentle approach, like best practice. If I'm using this as best practice, then I think other staff will watch and learn from that. I think we're often watching how other colleagues practice, and is that the type of nursing care that you want to provide to your patient? I also think that by having a conversation about this list, that will make people start to think, this is not a dual, list. This is to start those conversations on the unit. So if one month if you decide that this is a list that you're going to utilize on your unit, you can focus in on less restraints and say, is it possible to unrestrain this patient? Even for, as Matt had mentioned, a vacation. I often will unrestrain my patients and let my patient touch their face because they just want to figure out what the heck is going on with this tube in their mouth. And it's as easy as fixing the drooling, and they just want to wipe that drool away and then they're satisfied, they're happy, they're not trying to pull on their restraints. And so if you can trust them, and it has to do with nurse-patient ratios, you have to be able to assess your patient and be in tune with what your patient is doing.
Perfect. I agree, Kathy. I think these lists are great ways to start those conversations with colleagues. So it's a great way to start and to change practice, not necessarily to adopt everything in this list, but to see what is relevant to your organizations and to your units. I think we've addressed most of the questions here. Kathy and Matt, do you have any last words?
No, there were two small questions about just evidence-based recommendations regarding the use of in and out catheters, and then should we be exchanging Foley catheters every 7 days? So those are two valuable questions. I think for the purpose of this talk, however, the recommendation is just to minimize the Foley catheter as best as possible. So what that looks like within your institutional policies or within your order sets might have to go back to your nursing educators and or management or physician team to see if there are better ways to provide continence management or replacement of Foleys within a certain time frame. But our recommendation from this list is try to minimize that invasive line as quick as possible.
Perfect. Thanks, Matt. And thank you for catching those questions there. So again, I'd like to thank Kathy and Matt for this really excellent presentation and for the great engagement from all of our participants. We hope this session helps stimulate some of your thinking about the critical care nursing list. And again, you'll have access to the lists both in the emails as well as from the YouTube recording. And the YouTube recordings will be emailed to you after this webinar. If you haven't already, please consider registering for our next webinar during Antibiotic Awareness Week, Nursing Leadership in Antimicrobial Resistance and Antimicrobial Stewardship, which will be held on Tuesday, November 19 from 12 to 1 p.m. Looking forward to seeing you all then, and thank you, everyone.